Jake is a 58-year-old retired postal worker who has been on your floor for several days receiving plasmapheresis every other day for myasthenia gravis. Before this admission, he had been relatively healthy. His medical history includes hypertension, controlled with metoprolol, and glaucoma that's treated with timolol. And about a year ago, Jake started experiencing difficulty chewing and swallowing, diplopia, and slurring of speech, at which time he was placed on Mestinon. And recently, Jake was diagnosed with a sinus infection and treated with Cipro. On admission, Jake was unable to bear any weight or take fluids through a straw. There have been periods of exacerbation and remission since his admission. Jake's wife asks you what may have caused my husband to get worse. So what kind of explanation would you give her? Well, the antibiotic ciprofloxacin your husband was given for his sinus infection can cause profound muscular weakness in patients that have myasthenia gravis. There are other antibiotics that would treat the sinus infection without causing this muscle weakness. And you are visiting with Jake's wife, who tells you she doesn't have a lot of information about MG and she would like to know more about it so that she would feel more comfortable talking to her husband. What should you tell her? Well, it is a chronic disease that affects the transmission of signals from nerves to muscles. It is believed that Jake's immune system produces antibodies that block that transmission. The muscles cannot work very well. This is exhibited as muscle weakness. Myasthenia gravis usually affects eye movement, facial expression, chewing, swallowing, speech, breathing, and head control. The muscle weakness increases during activity and improves after rest. Myasthenia gravis affects people of all ages and ethnicities. Women are affected more than men by a 3-to-2 ratio, and the highest incidence is noted in women in their 20s and 30s and men in their 50s and 60s. It is not directly inherited, and it is not contagious. Myasthenia gravis is a chronic disease characterized by remissions and exacerbations of fatigue and weakness, primarily in muscles innervated by the cranial nerves, as well as in skeletal and respiratory muscles. This autoimmune disease of the neuromuscular junction may take many forms, from mild disturbances of the ocular muscles to rapidly deteriorating generalized weakness that may lead to death from respiratory failure. Jake's wife asks you to explain what to expect in terms of signs and symptoms of her husband's illness as it progresses. What should you tell her? Well, MG usually comes on gradually, although it can progress rapidly with respiratory infections and emotional upset. How fast the disease progresses varies from person to person. Early symptoms in most patients are ptosis and diplopia, but the pupil response to light remains normal. The next muscles to be affected are the facial, masticator, speech, and neck muscles. Thus, when the patient chews, he becomes tired and must rest. There may be problems in managing saliva because of difficulty swallowing. Generalized weakness develops in approximately 85% of patients. The muscles of the arms, legs, diaphragm, and neck are affected. A myasthenia crisis exists when the intercostal muscles and the diaphragm are involved and breathlessness and dyspnea are present. A muscle group affected tend to be weaker after use or towards the end of the day when the patient is fatigued. Motor manifestations are progressive muscle weakness proximal that usually improves with rest. There's poor posture, ocular palsies, ptosis, weak or incomplete eye closure, diplopia, respiratory compromise, loss of bowel and bladder control, and fatigue. Sensory manifestations are muscle achiness, paresthesias, decreased smell and taste. Jake's wife asks how the disease is diagnosed. How do they know that my husband has MG? What should you tell her? The diagnosis of MG is based on history, physical, and neurologic examination and confirming lab testing. The patient usually reports that specific muscles become weak with activity and that a period of rest improves the function. Myasthenia gravis does not affect reflexes, coordination, or sensory perception. Confirmation of MG is based on the results of the following tests: anticholinesterase test, antibody titer for acetylcholine receptor test, nerve conduction test, and the single fiber EMG. The anticholinesterase test, the drug that is commonly used is androphonium or tensilon, because it has a rapid onset of 30 seconds and a short duration of about 5 minutes. This test consists of administering tensilon 2 milligrams IV. If no adverse symptoms appear, another 8 milligrams is given, and there is improvement in the muscle strength of the previously weak muscle, and that will last for 5 to 10 minutes. The test is considered positive. The antibody titer for acetylcholine receptor is conducted by an assay of blood. 80 to 90% of patients with generalized myasthenia have an elevated antibody titer. The repetitive nerve stimulation, while electrical shocks are delivered to a nerve at the rate of 3 per second, surface electrodes over the muscle record electrical potentials. A rapid reduction of the amplitude of the muscle potential is considered positive. The single fiber EMG this test can detect delay or failure of neuromuscular transmission in pairs of muscle fibers being supplied by the branches of a single nerve fiber. It is about 90% sensitive in confirming MG. And then mediastinal MRI or CT, they're looking at the mediastinal cavity to identify an abnormal thymus gland or a thymus gland tumor. Many people with myasthenia gravis have a thioma. Jake's wife asks, what are some of the options for treatment of MG, and how would you explain the different treatments? Several therapies are available to reduce muscle weakness. Most people have good results from treatment. 4 options are useful for the treatment of MG: anticholinesterase drugs, immunosuppressive therapy, plasmapheresis, IVIG, and thymectomy. After the diagnosis of MG has been established, an individualized management plan is developed, since no single treatment plan is effective for all patients. The goal is to achieve a quality of life that is symptom-free as possible. The anticholinesterase drugs are the first-line approach for the management of the symptoms of MG, although they do not treat the underlying disease. Prostigmine is the most commonly used drug, and these drugs help to improve nerve signals to muscles and increase muscle strength. Immunosuppression and glucocorticoid steroid are used for those who do not respond well to the anticholinesterase drugs. Long-term corticosteroid therapy may be tried. Prednisone is the drug of choice, producing marked improvement or remission in about 70-80% of cases. Cyclosporin or Imuran may also be used to suppress the production of abnormal antibodies. Plasmapheresis or plasma exchange is a method whereby the circulating antibodies, especially the abnormal antibodies, are removed from the blood. This does not treat the underlying abnormality, the production of the anti-receptor antibodies over the long term. It just removes them. The treatment takes 2 to 3 hours to complete. An antecubital vein or a shunt is used, so these patients are like renal patients if they have a shunt in place, or dialysis patients. The indications for plasmapheresis are to stabilize the patient in a myasthenia crisis or to serve as a short-term treatment for a patient undergoing thymectomy. An improvement in muscle strength is usually noticed in 1 to 5 days after the first exchange, but it is temporary. IVIG is a treatment temporarily interferes with the immune system's ability to damage the nerve-muscle junction. The indications for the use of IVIG are the same as for plasmapheresis, short-term treatment for single relapse of MGs. As with plasmapheresis, improvement occurs within a couple days. A thymectomy is the removal of the thymus gland, and this surgery is done with people who have myasthenia gravis who actually have tumors in their thymus, as well as those without tumors. About 85% of patients experience improvement in their myasthenia gravis after surgery. An additional 35% have drug-free remission after thymectomies. So what factors could predispose Jake to an exacerbation of his illness? Infection, surgery, stress, increased or hard physical activity or exercise, overexerting himself, sedative medications, enemas, poor diet, or strong cathartics. Jake's wife asked what physicians and nurses watch while her husband is in the hospital. So how do you explain these activities? Well, we assess the respiratory function by auscultation and observation, evaluate respiratory tests such as tidal volume and vital capacity. We observe for unwanted side effects of drugs, excessive sedation, decreased respiration, agitation. We assess for the strength of all muscles involved, respiratory rate, rhythm, quality, abdominal breathing. We assess the quality of voice, hand strength, and equality of that strength. We assess leg movement, assess ocular muscle and ptosis, assess neck muscle ability of the patient to hold up their head. When we're doing a nursing assessment, we're going to look at the patient, see how long does it take for them to eat. Does speech and swallowing worsen over the course of the meal? Does taking Astignon take 30 to 45 minutes, taken 35 to 45 minutes before the meal, improve their swallowing? Is the patient coughing while eating, which is a sign of aspiration? Is there nasal regurgitation with fluids or foods, and can the patient chew meat, bread, etc.? So our plan for optimal care of our patient with myasthenia gravis and dysphagia would include monitoring and watching them eat, doing calorie counts, fluid balance documentation, watching their weight, temperature, auscultate their chest, looking for signs of aspiration. As worsening occurs, discuss with the patient the possibility of enteral feeding, such as a G-tube or a PEG, J-tube, a nasogastric tube. Swallowing assessments should be done by speech pathologists as well to assess for silent aspiration. Jake's wife wants to know when he will be able to go home. How should you respond? What information will she need before taking her husband home? How should you explain this to her? Both Jake and his wife should be aware that and understand the dose and purpose and potential side effects of their medications. To take the medication with a small amount of milk, bread, or crackers to reduce the risk of nausea and gastric irritation. To avoid taking medications with fruit or coffee, fruit juice. Take medications long enough before eating a full meal to maximize the strength of the muscles for chewing and swallowing. Eat a high protein, high carb diet. Take small, frequent meals to avoid fatigue. Do not take over-the-counter medications without your doctor's consent. Understand the difference between cholinergic and myasthenic crisis and know the signs and symptoms of each. An Ambu bag and portable suction device should be available at home for patients who are prone to crisis, and they should both understand how to use it. Jake should wear a medical alert bracelet to identify him as having MG and carry a card stating his name and the name and telephone of his physician. He should eat slowly and select a soft diet if he is having difficulty swallowing. Relapse of symptoms can be caused by infections, extreme temperatures, excessive exposure to sunlight or ultraviolet light, and emotional stress. Schedule adequate rest periods during the day, pace himself and set priorities and plan ahead to avoid undue fatigue. Wear sensible shoes to minimize weakness and loss of balance, and do not drink alcohol. Most patients with MG are managed at home once any crisis has been resolved. The treatments are completed and the medication regime is optimized. Jake will continue to need assistance once he's at home. Discharge planning should work with and teach Jake's family members who are involved in his care at home. They should also be educated in CPR. Jake's wife asks you, what's the difference between a cholinergic and a myasthenic crisis? What explanation do you give her? Well, a myasthenic crisis is a sudden relapse of myasthenic symptoms in a patient with moderate to severe myasthenia or generalized myasthenia. A cholinergic crisis is an event precipitated by toxic effects of anticholinesterase or cholinesterase inhibitory drug and the subsequent side effects. It is essentially a problem of overmedication. What supportive measures can you suggest to Jake's wife that she can undertake or arrange on behalf of her husband? She could take him to an MG support group, can discuss with him what he would like to do for intellectual stimulation when he cannot get out as much as he would like. Suggest that she spend time with a neurologic nurse and a social worker, a PT, an OT to understand what part of each plays into caring for a patient like Jake. Living in the community after being diagnosed with myasthenia gravis is dependent on a supportive, knowledgeable family and base of friends, adherence to the medication, and awareness of the events that may trigger an exacerbation, and conservation of energy to avoid fatigue.